Hello everyone, this is Dr. Skorbeck. I am recording a webinar titled Transitions of Care, What Does It Mean? First, I would like to talk about the basic requirements for a TOC visit and also what the true meaning behind us doing these visits is. So the importance of TOCs is that they prevent unnecessary readmissions. They ensure patients receive the care that they immediately need after discharge, which is very important. And it also reduces costs, both for patients as well as the healthcare system in general. Studies have looked for root causes of why TOCs become ineffective, and some of the biggest problems are communication breakdowns, just patient education breakdowns, as well as accountability breakdowns. In this sense, the Transitions of Care visit allows us to work on improving these areas by having an open line of communication with our patients, educating them and their caregivers about anything that may have been confusing for them in the hospital, and also for us as primary care doctors to take accountability and responsibility for our patients after they are discharged from the hospital, so they have someone to turn to if they have questions about what happened in the hospital. So what are some of the basic requirements for the Transitions of Care visit? So TOCs are required for patients after certain types of discharges. I'll go into more detail into the qualifying types of discharges in my next line. Also, healthcare professionals accept the care of the patient post-discharge from the facility setting without a gap, meaning we don't wait long to see these patients, at the most 2 weeks before we see them in our office, so that there is that continuity of care. And also the healthcare professional takes responsibility for the patient's care. So this is where that accountability for our patients takes place. So what type of discharges qualify for a Transitions of Care visit after discharge? First and foremost, any inpatient admission. So this could be admissions into an acute care setting, a long-term care setting, a rehab facility, and also psychiatric admissions count as well. Also discharges from skilled nursing facilities. So after, somebody was in the hospital and then was discharged from a skilled nursing facility, we could also bill for a transition of care visit. Hospital outpatient observation settings. For example, somebody who's been in the ER for a long time and then they need an additional 24 to 48 hours to have whatever issues or problems that they were first seen for in the ER resolved, they would get switched over to observation, and we can bill for those as a Transitions of Care visit. Medical partial hospitalizations. So these types of hospitalizations are actually related to behavioral health, and essentially they are for patients who need more therapy than a traditional outpatient behavioral health setting could provide. And then partial hospitalizations in community health, mental health centers. So same thing, patients who need a little bit more therapy than a traditional outpatient behavioral health type of setting could provide from them. Another requirement for billing for a Transitions of Care visit is that the patient has actually returned to their home setting. So this could be a physical home, it could be an assisted living facility, a rest home, a halfway house, a VA center that has housing. So as long as the patients are back in their usual place of living after the discharge, they would qualify for seeing us in a Transition of Care visit and for us billing for that. If a patient, for example, is discharged to a skilled nursing facility, we cannot bill for that unless the patient is discharged from that skilled nursing facility. We would have to wait until they are home before we could see them and bill for that type of visit. So what are some of the components of a TOC? There's essentially three. The first is an interactive contact, and I'll get into a little bit more detail about what this means. The second is a face-to-face visit with their provider. And the last is certain non-face-to-face services that can be provided by other staff. And I'll go into detail into all three of these components in just a few minutes. On this slide, I'll discuss the interactive contact. So what the interactive contact entails is making a contact with the patient or their caregiver within 2 business days following discharge. This can be done in several ways. It can be done via telephone, email, or face-to-face. There has to be a successful exchange of information and medical direction between the clinical staff and the patient or caregiver. So simply leaving a voicemail or email with the patient is not enough. There has to be an exchange of information. Also, if we've documented that we've attempted to make 2 contacts with the patient or caregiver, that counts as well. And for Medicare patients, attempts to communicate should continue until you reach the patient or the caregiver. One other service that the provider can include in their transition of care visit with the patient is any non-face-to-face services. So things such as reviewing a discharge summary or any documentation that was either faxed over or as part of the patient's EMR that was related to their hospital stay. Also reviewing any type of pending diagnostic testing or treatment. So if a patient had lab tests or CT scans that weren't resulted prior to their discharge, we could also review those, or try to obtain more records about any type of testing that may still be pending from their last hospitalization. Another big thing is just interacting with other healthcare professionals. So any specialists that saw the patient in the hospital, communicating with them, clarifying diagnoses or treatment plans with those providers. And then a big part is providing education to the patient or caregiver. So if any clarifications have to be made on diagnoses or treatment plan or medications, we would provide the patient with those as well. And then establishing referrals and arranging for needed community resources. So if the patient did need a referral to a specialist and was not given that information in the hospital, or that appointment wasn't made for them, we could also provide them with that service. And then also assisting in scheduling and required follow-up with the community providers and services. So again, if they need an appointment or a visit with another physician or even somebody in the community, a provider such as a social worker or an addiction specialist, we could provide those services and help them with that as well. In addition to services that are provided by the provider, other staff can also provide services for the patient during the transition of care, visit, and interaction. So things like providing education to the patient or the caregiver to support self-management, independent living, and activities of daily living. These are all things that don't necessarily have to be done by the provider, but can be done by a social worker or another staff member in the office to ensure that the patient is doing everything that they can or that they were doing before they were discharged from the hospital. And then assessing and supporting treatment regimen, adherence, and medication management. So again, not coming up with a treatment regimen, but supporting the regimen that's already in place or that has been emphasized during the transition of care visit. And then identifying, referring, and communicating with agencies and community service used by the patient. So if the patient needs transportation services, food services, obtaining medications in certain ways, these are all things that other staff in the office can also help the patient with. And then assisting the beneficiary or family in accessing needed care and services. So if it's a caregiver or somebody else who's helping the patient and they need some sort of information or access to some sort of care after their discharge, we would help them with that as well. So how do we bill for the face-to-face visit? There are essentially 2 codes. One is a CPT code of 99495, and this is when the patient sees us within 14 days of discharge. And the other one is a face-to-face visit CPT code 99496, and this is when the patient sees us within 7 days of discharge. So essentially, it's the time frame that we're seeing the patient in our office after their discharge. Another requirement is that the office visit does have a moderate to high complexity of decision making. For most of our patients, this will not be difficult, since most patients, if they're admitted to the hospital, do have multiple problems, and there are multiple levels of decision making that have to take place both in the hospital and after the hospital. So in this case, this usually shouldn't be an issue for us, as I mentioned, there are usually multiple problems and factors that go into our medical decision making. So here at Alliance Health, we do have a dedicated person to the TOC process. What they'll do is they'll make patient outreach calls, they'll request records, they'll do medication reconciliations with the patient or the caregiver over the phone, and they'll also perform a brief assessment. So if there are any unmet needs or urgent needs that have to be addressed prior to the patient coming in to see us in clinic, they will help with those as well. The staff are doing emergency department TOC follow-up. So they're calling the patient after they're discharged from the emergency room and seeing if there's anything that has to be done for them before they come in to see us. These visits, the emergency room visits, TOCs, aren't billed as a traditional TOC, they're billed as an office visit. And we can also continue billing as a traditional TOC visit as long as all the conditions are met, as I've mentioned before. Now I'm just going to go over a few frequently asked questions. So one is, if Medicare only pays one provider for a transition of care service within 30 days of discharge per patient, how will Medicare determine which practitioner to pay if more than one provider bills the service? So an example of this would be somebody going to their primary care doctor, that provider billing the visit as a transition of care visit, and then perhaps a few days later going to a specialist and that person also billing for a transition of care visit. So Medicare will only pay the first eligible claim submitted during the 30-day period that commences with the day of discharge. So whoever the patient sees first and whoever bills for that visit first is who Medicare will pay. The next frequently asked question is, can medication reconciliation happen after the face-to-face visit? And the answer to this is that medication reconciliation and management should happen no later than the face-to-face visit. So it can happen before, it can happen during, but it cannot happen after the patient is seen in our clinic. The next question is, do the codes apply to new patients as well? And yes, they absolutely do. They apply both to new and established patients. So if you see somebody who is new to you but has recently been admitted and discharged from the hospital, you can still bill for a transition of care visit for that patient as well. And the last frequently asked question is, will we always have the discharge summary hospital records available when the patient comes in for a TOC? In the best case scenario, yes, we always would. And that would always be very helpful to us, not just for the purpose of billing for a transition of care visit, but also so that we can give the patient the best care that they need. But a meta-analysis actually found that only 12 to 34% of discharge summaries had reached outpatient care teams by the time the patient saw a physician. Unfortunately, for billing purposes, we do need the hospital record to bill for a TOC. So we have to make every effort to try to either obtain that through a fax or through the electronic medical record prior to the patient coming in for their visit.